Hi, Mike Gibson, Renato Lopez coming to you live from ESC 2025. And we're talking about the PARACHUTE trial, the treatment of heart failure and Chagas disease. Renato, say a few words about Chagas and then tell us about the design of the study and what you found.
Sure, thanks, Mike. So Chagas disease is a disease that was primarily coming from Latin America. So we have about 7 to 8 million now worldwide, not just Latin America. Interestingly, Mike, we have about 400,000 people affected living in non-endemic areas like the US and Europe. So it's
Hmm.
really with the migration of people to other places, it's becoming not just something related to South America, of course, although the majority of cases are still in South America. And we know that one of the most important complications of Chagas disease is heart failure. So for the chronic form of Chagas disease, heart failure is one of the most complicated and devastating adverse outcomes that can happen in this population with Chagas. And uniquely, the Chagas heart failure has some really interesting features, such as lower prevalence of traditional risk factors like hypertension, diabetes, coronary artery disease compared to other heart failure etiologies. But nonetheless, they have worse outcomes. They have higher mortality rates. They have worse quality of life. So it's a really high risk population. And unfortunately, underrepresented in most of the trials, most of the heart failure trials. So with that in mind, Mike, we wanted to do and perform a very well-designed and dedicated trial on heart failure due to Chagas disease to test some of the drugs that are available for heart failure in non-Chagas disease. So that was basically the rationale for doing the trial. And then in the trial, basically what we did was include patients with low ejection fraction, so less than 40 or equal to 40 of ejection fraction. Of course, positive test for Chagas disease, no other possible etiology for the heart failure, and of course, heart failure class, New York Heart Association class from 2 to 4. So basically, an elevated NT-proBNP. So basically, very similar to the paradigm inclusion criteria trial, but now in Chagas disease. So basically, testing sacubitril/valsartan versus enalapril in this population.
And what did you find?
Well, so the primary endpoint of the trial, Mike, was a composite endpoint of time to CV death, time to first heart failure hospitalization, and then a relative change in the NT-proBNP value from baseline to week 12. So it was a hierarchical endpoint using the win ratio. And basically, after screening over 1,800 patients and randomizing 922 patients, Mike, basically we have a win ratio of 1.52. So in other words, highly statistically significant. So in other words, a 52% higher likelihood of a better outcome in patients assigned to sacubitril/valsartan compared to enalapril. Of course, when you look at the breakdown for CV death, there were more wins numerically on sacubitril/valsartan, but not statistically significant difference. There were more wins in the sacubitril/valsartan for heart failure hospitalizations, although also not statistically significant different. And the primary results of the win ratio was primarily driven by a 32% reduction in the rates, in the levels of NT-proBNP at 12 weeks. So again, positive trial, Mike, primarily driven by NT-proBNP, a 32% reduction, but nonetheless, I think an important platform that was created to generate high quality evidence in a neglected disease such as Chagas disease that can hopefully be used now in the future for other treatment options.
Well, I didn't know the global extent of Chagas outside of South America. I was kind of shocked to see that many patients. Here you use NT-proBNP as a surrogate, as the anchor of the win ratio. Everything went in the direction of the drug that was superior here, which is reassuring. But how good of a surrogate is NT-proBNP for hard outcomes?
Yeah, I think that's a great question, Mike. And I think particularly when you look at all the data, which is a vast amount of data on NT-proBNP for heart failure outcomes and for heart failure population, I think with all the skepticism that we have to have with surrogate endpoints and all the caution that we have to have with them, I think that NT-proBNP, Mike, for heart failure population and heart failure outcome might be almost the perfect surrogate endpoint. Because again, I think it has been highly related with worse outcome, heart outcomes in many, many studies. And the higher the level, the worse is the outcome. The lower the level, the better is the outcome. So again, we didn't power the study, Mike, to find a significant difference in mortality and in heart failure hospitalization, because otherwise we will need 8,000 people trial. And again, it's very hard to do a trial in Chagas population. But nonetheless, we pre-specified that the win ratio needed to be positive, highly significant, but the hazard ratio in the CV death and the hazard ratio in the hospitalization due to heart failure needed to be in the right direction. In other words, needed to be hazard ratio less than 1, favoring sacubitril/valsartan, and that's exactly what we found. About 9% relative risk reduction, of course, not statistically significant, but numerically in the right direction. So I think with all the combination of what we know about these agents, sacubitril/valsartan, plus what we know about Chagas disease, plus what we know about NT-proBNP being highly prognostic in heart failure outcomes and heart failure populations, I think our study gives really important information, Mike, for the decision-making process in the day-by-day practice.
Well, we often say, well, you should have done a trial of 8,000 patients, but if the trial's never going to get done, sometimes it's better to do something like what you did with the win ratio to shed some light on the issue. So congratulations, Renato, on a very well executed trial. Thanks for joining us today, and thanks to all of you for joining us here live from ESC 2025.
Thanks, Mike.